Hi, my name is Michael Zen. I'm going to be instructing you on 10 different suture techniques, as well as a stapling technique for skin closure. Now, if you're going to be good at suturing, you need to practice. And here at Duke, we rely on cadaveric material and animal material for practicing, and that's not really very cost effective and not very practical if you want to practice anywhere you want. I'm going to be instructing you on VADA's new Suture Skills Simulator, which is a simulation device I helped to develop. It's incredibly lifelike and really feels like you're operating and suturing on normal tissue. I certainly would like to thank VADA for supporting this video. I think this suture product that they have made has been a long time coming. It's incredibly realistic, it's compact so you can take it wherever you want to go, and it really is a complete solution for anybody who wants to practice suturing. All right, before we get started with teaching different types of suturing, I want to teach how to tie the knot. The simplest way to do this is with an instrument tie. You simply pass whatever suture we're doing into the skin, and when you're ready to tie it, what I'd like you to do is pull the suture all the way through, but leave a small short tail, about 1/4 of an inch, 1/2 inch is plenty. So you'll have a short end and a long end. And we're going to keep this pretty simple. You take your needle driver and you're just going to simply place it between the two. Take the long end and then wrap it. And you want to wrap it twice. And then grab the short end and then pull the short end across the wound to the other side. And what that does is it locks the wound down. See how it sits there and doesn't move. For the next throw, I'm going to wrap the needle driver again. And this time just wrap it once. I'm going to grab the short end and pull it across, but don't pull up on it. You just want to tie it down until it gets down to the knot and then lock it down. Okay? Then simply put your needle driver between the two again. Wrap it with the long side, grab the short side, and pull it across. So you're doing the same thing every time. The first time you're wrapping it twice, and that's called the surgeon's knot. And that'll lock it in place, because what you don't want is you don't want the knot to be loose. You want your skin well approximated. So we call that an air knot when it's not approximated. So just to review one time, once your suture is placed, leave a short tail, wrap the needle driver twice, pull the short end to the other side, locking it. Now don't pull up on it, wrap just once around the needle driver, pull it back to the other side, lock it down. And now for your next throw, you can go ahead and wrap it once again and pull it to the other side. Now some absorbable suture, you may need to do it 4 times, but 3 times for permanent suture, like the suture that comes in your kit, is fine. So the first suture I want to teach you is a simple suture. Simple because there's really only one part to it. You're simply going to put the needle in on one side and then put it through on the other side. So it's important to hold the needle in the middle, enter at 90 degrees, exit, and then try to enter again so you can come into the tissue and come up at 90 degrees. Having it 90 degrees on both sides, when you tie it, will approximate the skin beautifully. So that's why I like to do it in 2 and not try to just run the needle all the way across. Do the instrument tie, as I've already taught you, and see how nicely the skin is approximated. And you'll see as you start doing this more and more, you'll just get faster and faster. It is an acquired skill. So the key, enter at 90 degrees. Sometimes you can keep it in, but you push the skin just to make sure you're getting through it at 90 degrees. And again, that's going to help you to reapproximate your skin. Now you'll decide how far apart each stitch needs to be. The closer they are together, the more stitching you're going to be doing and the more scar you may have. Some tissues are already just about approximated, so you don't need that many. Now I'm going to show you a simple buried suture. These are the sutures that we use when we're trying to reapproximate the skin, usually with absorbable suture, and then either gluing or steri-stripping where we're not doing a skin layer. So the key here is you want to get some of the deeper tissues, and here you see in the model we can get some of the deeper dermis. And there's actually a little piece of mesh in that deep dermis. So we want to grab that deeper stuff, come out superficially, so we're starting deep, and then we enter superficially and end deep. So both threads of the suture are now deep. And what that's going to do when we tie this now is it's going to pull everything together, but the knot itself is actually going to be underneath. And this is important because we want to take all the tension off the skin, whether we're steri-stripping it or whether we're just closing it with another suture, and we don't want these little ends of the suture to poke up through the skin. We call that spitting. So you need to get deep, grab some of that deep dermis, which in this case is that little piece of mesh, and make sure you're entering the same place where you exited on the other side. So just as superficial as you are on one side, you must be superficial on the other side, or else your skin edges will be uneven. Notice also when I'm pulling, oftentimes I'll pull it along the wound. It allows you to get the tie all the way into the wound, and it's not being prevented by the skin edges. So this is a simple buried suture. This is something that we use all the time in plastic surgery. Next, I'm going to show you a little more complex suture, the vertical mattress suture. Again, we're going to go ahead and open up the device that comes with your suture pad that helps to put tension on the skin. And when we go ahead and make a cut here, what happens is the skin gapes open. In order to take tension off this, sometimes a simple suture will just pull through, and we'll do a vertical mattress, which some people call the far, far, near, near. So notice I've gone into the skin, along the bottom of the skin, and gone far away, and now I turn the needle around and come back and do nearer and nearer to the incision. And what this does is going to pull the tissue between each of those throws together, as opposed to just pulling the edges of the skin together. And again, you do your instrument tie, and generally I'll pull it tight just so I see the skin kissing. And this is a more secure closure, because now what you're doing is you're actually grabbing a bunch of tissue and a bunch of tissue, and it's pulling the skin edges together, but there's no actual stitch in the actual edge of the skin. So again, deep, run along the bottom of the dermis, run along the bottom of the dermis and come out about the same distance on both sides, turn the needle around, and now you want to get pretty close to the edge of the skin, because it's the distance between those two bites that gives you your strength. Do the same on both sides, and then again go ahead and do your instrument tie. So this is important when we are doing different types of deeper closures, and certainly wounds that are traumatic and maybe have edema and are swollen and under a lot of tension. Now this type of suture is going to be part of your armamentarium. Now sometimes you can change it to a horizontal position. So these are all in the same line, and hence the term vertical. Now we're going to do a horizontal mattress. Here the idea is not to go near, near, or far, far. Take the same size bite each time. But what you're going to do is it's effectively two simple sutures in one suture. So what you'll do is you'll enter the skin now as if you would for a simple suture. And instead of tying this as a simple suture, turn your needle around, move the same distance you would for your simple suture, and enter it the same way, almost like you're doing a simple suture on the other side. So this is still a mattress suture because there's two different rows of suturing, but now instead of in a vertical line, it's in a horizontal line. And it's important that you pull it together again only till the edges kiss each other. So it has the advantage of being faster than two simple sutures. And you know, sometimes in some situations you want to pull tissue to tissue together, just like with a vertical. Vertical is nicer because it does evert the skin edges, but in a case like this where eversion is not a problem, simply doing a horizontal mattress will help you. And sometimes in cosmetic surgery, we don't want any suture marks on one side. And when you come to the second side here, what you would do is take the first half of your simple and then just take simply a dermal bite on the opposite side and then come back and come through the skin again. And when you tie it down, it'll simply pull the dermis toward it. And we often do that in cosmetic surgery in areas of hair bearing. So this is good again for tension. It's good when the skin doesn't need inversion. Another variant of the horizontal mattress is called a figure of 8 suture. We'll often use this in general surgery where we have big wounds that are gaping apart or fascia and we need strength. It's placed in the same way. We do simple suturing and simple suturing, except this time, rather than turning the needle around, we simply just move along and take another simple bite and simple bite. So same distance, same spread, except now, because we didn't turn the needle around, we have suture crossing in the middle. And as we tie it, you can see it looks like an 8, hence the term figure of 8. And a figure of 8 is just as strong as a horizontal mattress would be, but it's faster. I would say cosmetically the scar would not be as good, so it's good for fascia in deep areas. Next, simple running suture. Now we're moving along. You're becoming a proficient suturer with your simple sutures. You could just put a series of sutures that are simple sutures and you'll close a wound much faster. I liken this to like a sewing machine. You'll want to take the exact same bite each time, and you want to advance the same amount each time. And that's how you get an incision, a closure to look pretty. So this is just a simple suture. You'll tie your first one with your instrument tie. Keep the length of your suture, long enough for the job, but not so long that your hands are going all over the place. And now what we're going to do is reload, and we're going to move along the same distance each time. And even though when we tie the stitch, it looks like it's closer to the skin, we need to enter the skin exactly the same place. So here it's just a few millimeters on each side. Move along the same distance. Here a few millimeters. Take the same distant bite on each side. And again, as you see, as you start to get better and better, you can just go faster and faster. And what's going to look nice is that you've done it exactly the same way each time. Now, because we're going straight across underneath the skin, outside we're going to see a slanted suture like a baseball. We sometimes call this a baseball stitch. If you want to get really fancy, when you're passing your needle deep to the skin, if you pass it on a diagonal, your stitches will look like they're straight across. So there are different ways to do it and different ways on how you want it to look. This is a suture that we do use all the time because it's fast and efficient. One variant of this is what's called the simple running locking suture. Sometimes you are closing a wound quickly, and an example would be maybe a big scalp wound where it's bleeding and you just need to get it closed. And it's hard because it's gaping open a little bit. As you start to tie your suture, it's not staying in place. Sometimes you can have an assistant hold that for you, but when you're by yourself especially, what you can do is you can lock the stitch each time. And what I mean by that is you take your simple bite, and now before you pull it completely through, you take the needle and you pass it through the loop. So now it's like a little pulley closed down and it locks it down. And then you go ahead and take your net stitch and make sure it comes back through the loop. And so what you see here is that you can do a pretty long suture line and not worry about it untying behind you as you go. Again, probably adds more suture to the skin, therefore it's not as good necessarily for cosmesis, but certainly for something like bleeding, like in a scalp wound or a wound where you're just trying to get something closed quickly, works perfectly. And I always end these types of running sutures just by grabbing the loop and then doing your instrument tie once again. Again, 2 times around will lock it. If you're having problems with it locking, you can even wrap it 3 times around the needle driver, and that really holds it in place. Only 1 time around for each subsequent. So now we're getting to fancier closures. A subcuticular closure is really what I would call a cosmetic closure. The idea here is to close the skin and not have any suture in the wound at all. So we'll go ahead and apply the Vada device to the pad so it spreads it apart for us or gives us a little bit of spread. And now what we're going to do is run a stitch under the skin, and this can be done either with permanent suture or absorbable suture, and I'll demonstrate here with permanent suture. So I'll enter from outside and enter just at the level of the deep dermis, and the key here now is to take horizontal bites in that deep dermis, exactly the same on both sides, and advance as you go. And what you see is I'm pulling the suture across to show where the next stitch should be, so I make sure there's no bunching. But what you can find over time is that it really doesn't matter how much you advance as long as you're doing the same each time. I will tell you, if you're hoping to pull this stitch out later, like maybe after a week, then you'd want to advance more each time. If you know it's a permanent suture that's going to stay in there, like something absorbable maybe, where you're not going to have to remove it, then you want to almost go back to the last stitch each time. So there are different variants, but the key is do the same thing each time. Now the skin is beautifully opposed, and on this I probably would still put steri strips or put some skin glue, but it's really the suture that's holding everything together. One of the advantages of the Vada pad is that all the layers of closure are represented. So we not only have the skin and dermis, we also have some fat, which feels very lifelike. And then deeper we see the white, what I will call fascia, or the lining of the muscle, and below is some red, which represents muscle. Generally the strength of closure, especially in deeper wounds, is going to be that deeper white fascia. So if we just close the skin here, there almost would be this potential space underneath where fluid could collect. or the skin would have so much tension on it, it would ultimately would pull apart. This is especially true over joints where you're bending the arm or bending the knee, and you might pull things apart. So what we'll do here is we'll first close the fascia. Because fascia is generally so deep to the skin, I usually don't bury the knot. You certainly could, but you don't have to. So for simplicity's sake, I just do simple suture here. In some situations, we might use a permanent suture here. Certainly you can use absorbable as well, so it's kind of surgeon's choice. And remember, you're pretty deep here, so you're going to want to not only lock the knot, but then once you're pulling things down, it's almost easier to pull it along the wound itself. Otherwise, the skin may prevent you from tying all the way down. So we're going to put a couple of interrupted simple stitches here to close the fascia. And again, you sort of put a stitch in, see what it does, put a stitch in, see what it does. You know, that's the way that we do it in surgery. Sometimes you need a lot of stitches, sometimes you don't. Stitches are foreign body, so potentially if you're worried about infection and things like that, you'd use an absorbable suture, so it's not going to hang around, or at least less permanent suture. If you're not locking, remember you can always throw an extra throw, like 3 throws, or you can just do what I just did, which is sort of lock it down by pulling on it. Once the fascia is closed, you kind of have a decision to make. You can go right to the dermis, or you can look for, in some parts of the body, there's what's called Scarpa's fascia. So you could potentially close another layer. Here I'm going to close the deep dermis, and it's going to include some of that fatty tissue, which would theoretically be like a Scarpa's fascia. But the dermis is the strength here. Again, this is a buried knot, because this is the next layer of closure. So we started deep and went superficial, and then superficial and deep. You can see there is some tension on this wound, and I think that's what I like about this demonstration and this type of model, is that it is realistic, and you can set this tension as much as you want, and early on you'll be able to close the ones without tension pretty well, and as you start moving along you want to put more and more tension on and see how good your knots are and how good your suturing is. Another word of advice I would give you is notice how I'm going to the ends first. The ends have the least amount of tension, the middle of the wound gapes open the most, and I think most of the time people want to close the middle first. If you sort of sneak up on it though and start closing the ends first, you'll take the tension off, so by the time you get to that middle stitch, it'll have the least amount of tension on it. So here we have 2, and I'm going to put one more. Notice I'm grabbing deep dermis, starting deep, coming superficial, and I'll grab right above the dermis on the other side, come out the same distance, and when I tie it together then, what we're doing is getting these skin edges closer together and getting them closer together at about the same level, so that when we're finally closed and the skin is closed, we have a beautiful closure. Okay, so now we have the dermis closed. Now we're going to have our skin closure. This is your closure of choice. You can do a running suture, you can do interrupted. This will totally be up to you here because it's a complex closure and I believe it's under a lot of tension. I'm using the vertical mattress. I told you this is probably the best suture for wounds that are difficult to close and under a lot of tension, because you're grabbing a lot of tissue to a lot of tissue, and because you're starting far away and because your second bite is close, what that does when you tie it, it literally everts the wound, and so the skin edges pout out, which gives you proper healing. If you don't place your sutures properly, the skin can turn in, and epidermis, the outer layer of skin touching epidermis, is not going to heal. So you'll take your stitches out and your wound will kind of break open, and you'll wonder why. It's because you didn't approximate your edges. Something we do fairly often in the operating room is skin stapling. It seems like it's a fairly simple thing to do, but what I would tell you is approximation of the skin is key. Oftentimes I'll use either 1 or 2 pickups to position the skin properly, everting it, bringing it together, and then taking a stapling device similar to the one that comes with your kit. Simply center the device on the skin, staple it down. It literally will grab the edges and then turn them in, which helps to evert their edges, which again is very helpful. So stapling is nice because it's fast and will turn the edges out. So here I'm approximating the skin, everting it, getting it close together so that the skin edges are touching, and then placing the stapler. And you don't need necessarily to push down very hard. I think a very controlled motion is key, that when you're stapling, the end of the stapler is not really moving at all. Try to grab it near the end of the stapler. You'll have more sort of torque advantage. And again, just like simple sutures, you have to decide how many staples you need and what each wound needs for approximation. In a case like this, if this were a complex wound, we have multiple layers of closure, a staple might be nice because I'm going to leave these staples in for a few weeks. And generally, where sutures can get infected, metal staples do not. Well, how do we take these out? This is a staple remover. Basically, it'll grab the staple, which is turned its edges in to approximate, and will open the edges of the staple, and then it'll straighten them so they pull right out. And so here you see as you push down on the staple remover, it unbends those ends of the staple, it aligns them so now they become straight, and then the staple will literally simply lift out of the wound, very simply. So we push down, spreads it, and as it straightens it, it just pops straight up. If you don't have a staple remover, you can also use a needle driver or a clamp and place it under the staple and just spread, and basically spreading is doing the same thing. It's straightening out. This is much less painful for your patient, though, if you can use one of these devices because, as I said, it straightens everything out and simply pulls out, and there's no pulling. Sometimes if the bending apparatus doesn't really straighten them completely, you can just, as you're stapling, rock it gently. And here's an example with just a needle driver where literally you just spread, so you're trying to open those tines, and as it does, it'll come out. If you're going to do this, it's usually better to do this on a patient who's asleep because it can hurt to remove staples this way. And again, sometimes you do need to kind of rock from side to side, just in case one side is not completely open.